Thanks so much, Tim, and welcome everyone. Super excited to be here this evening and to welcome everyone for another one live from Cleveland Clinic broadcast. And the topic for today is a topic that is extremely interesting and something that we deal with on a weekly basis and can sometimes be very complicated. And we're very lucky to be working as part of a large multidisciplinary team with many of our multidisciplinary team members participating as panelists here today. So thank you to over 700 healthcare providers that are registered for today's event from really across the globe. You can see the map here, representing nearly 80 countries. And we want this event to be as interactive as possible. So please use the chat box to submit any questions or comments. And when we have the Q&A session, we'll have potentially address some of these comments, but also we'll ask all the panelists as they see questions come up that fall within their expertise to please feel free to answer any questions that come through the chat box. So please submit any questions you may have. And then finally, I want to thank our industry sponsors for the generosity in providing educational grants for the 2026 series, and that is Cook Medical, Johnson & Johnson, and Medtronic. So thanks for the generous support. And without further ado, I want to move on to introductions of the panelists, and I'll hand it over to Dr. Miller, one of our staff radiologists here, works very closely with us on our multidisciplinary team. Our tumor board wouldn't run without him. So Jacob, please take it away.
Thank you very much, Dr. Liska, for that very kind introduction. As Dr. Liska mentioned, it really is, we're quite lucky here at the clinic to work in such a multidisciplinary group to care for this difficult problem of locally recurrent rectal cancer. Our first panelist and speaker is Dr. Ehsan Balagamwala, who's staff in the Department of Radiation Oncology here at Cleveland Clinic's main campus. He joined our department in 2018 after completing his residency in Cleveland Clinic. He was actually a mentor of mine when I was a medical student at Cleveland Clinic, and I've learned a lot from him. It's been just a pleasure working alongside him over the past few years. He's pioneered a lot of our efforts actually in re-irradiation for rectal cancer, including new techniques, how to work in our multidisciplinary group. So I just want to introduce Dr. Ehsan Balagamwala, who will be discussing preoperative and intraoperative re-irradiation techniques for locally recurrent rectal tumors.
Thank you, Jacob, for that very kind introduction. So thank you again, Dr. Miller, Dr. Liska, Dr. Chung, for inviting me to speak. This is a topic that I hold near and dear to my heart. So very excited to speak with so many colleagues around the world. I'll review some of the data for re-irradiation in GI cancers, review some of the challenges that arise with re-irradiation, especially in rectal cancer, as well as discuss different techniques that are available for re-irradiation. So as we all know, recurrent rectal cancer incidence has gone down with the utilization of preoperative chemo-RT as well as TME. However, can still be up to about 20% in modern series, and local recurrence from rectal cancer is extremely morbid. For those of us that see these patients, we know how extremely morbid it can be. And so managing that not only has a survival implication, but also a significant quality of life implication. And so initially in the re-irradiation setting, there was a thought that hyperfractionated re-irradiation, meaning either twice a day or 3 times a day radiation in smaller doses, would offer increased opportunity for tumor cell redistribution and reoxygenation between dose fractionations, and a possibly lower oxygen enhancement ratio with the small incremental doses. And the important thing being that with the differential sparing of late reacting normal tissues, potentially for late toxicity, that risk would go down. And so one of the largest publications of hyperfractionated radiotherapy experiences comes from MD Anderson. This is their publication from 2017, where they reported their outcomes on 102 consecutive patients. And they defined their target for re-irradiation as the gross tumor volume, or the GTV, and they gave it a margin of either 1.5 to 2.5 centimeters or up to a 3 centimeter block margin. The treatment technique was old school 3D conformal radiation in the majority of patients, in about 86%. And the treatment intent was preoperative for about 2/3 of those patients, and about 1/3 of them had palliative treatment intent. And as you can see here, 39 gray and 26 fractions BID, so in 13 days, was the most common fractionation scheme that was utilized. Majority of patients, about 91% of patients, received concurrent chemotherapy. And about 45% of patients underwent eventual surgical resection, and we'll talk about the importance of that as well. When looking at the overall cohort, the freedom from local progression was about 50% at 2 years, dropping down to about 40% at 3 years, and the overall survival curve that you see on the right. Importantly, the patients that underwent surgery not only had a significant improvement in local control, but they also had a significant survival benefit. And so this underscores the importance of multidisciplinary management and expertise, not only in radiation therapy, but also medical oncology and surgical oncology and colorectal surgery. In terms of palliation of symptoms, of the 19 patients that had pain, proportion of patients that had symptom relief, about 80% had pain relief, and that duration was not very long, but nine months. Those patients that had bleeding had a 100% response rate, underscoring the importance of radiation in managing bleeding in rectal and bladder cancers, and that symptom relief from bleeding lasted almost 2 years. And urinary obstruction improved in about 2/3 of patients as well. And so what they also found was if the initial radiotherapy dose was either 54 gray or more, the risk for grade 3 to 4 toxicity was twice as much with re-irradiation. And if the retreatment interval was less than 2 years, the risk of grade 3 toxicity was also significantly higher at 43 versus 16%. And as one would expect, patients that underwent surgery also had a higher risk of toxicity, and that's because of combined modality toxicity, and that's expected. And so they concluded that surgery after re-irradiation provides the best local control. And without surgery, re-irradiation provided pretty suboptimal local control at only about 50% at 1 year and 30% at 2 years. And what they called acceptable toxicity was about 1/3 to 40% of patients with significant grade 3, grade 4 late toxicity, which to me is a little bit higher than I would like to see. And so what are some other options that one can utilize in this setting? And low-dose rate brachytherapy is an option that's been reported a lot out of Europe, where Patterson-Parker planar implants were used. And this is a study looking mostly at gold and cesium for implants, small recurrent volumes, and certainly requires a lot of expertise, procedural expertise. And the median follow-up 16 months, the local control was significantly better at 73%. Other options, there's a lot of talk about proton radiotherapy. And this is a study where hyperfractionated radiotherapy was used to a median dose of 61 gray. And as you can see in the diagrams here, the radiotherapy is very conformal, meaning it is only being delivered to that area. And one of the benefits of proton therapy is that there is no exit dose or low dose spill in the rest of the body. And these diagrams show very nicely that spread. So very small study, 7 patients with a median follow-up of about 20 months. One of those patients was, achieved a metabolic and anatomic complete response. 1 patient developed progressive disease, and 5 patients had a partial response. 2 of those developed a local recurrence. Importantly, 3 of the patients had pain complete response, and 3 patients had a partial response in their pain. This is a busy slide, but what it's highlighting is the low risk of grade 3 and grade 4 toxicity. So most of the toxicity was grade 1 and grade 2, which is much milder than what we saw in the MD Anderson series, looking at hyperfractionated X-ray radiotherapy. And so one of the other options that is currently being developed and in some places more mature is SBRT, or stereotactic body radiotherapy. This is just a slide showing the difference in biology when we use SBRT, or high doses per fractionation, where we're also impacting vascular endothelial cells as well as tumor stem cells, in addition to the tumor cells themselves as well. And this is a study from our colleagues in the UK, where they utilized SBRT. As you'll see here, the median dose was 30 gray in 5 fractions. And it was small targets, about 14 cc was the median gross tumor volume, and they had good follow-up of about 2 years. And what they saw was a significant improvement in 1-year local control compared to conventional, where they had 85% local control at 1 year and 70% local control at 2 years. Importantly, you'll see that there is less local regional control, meaning patients were failing adjacently or in the nodal regions. Again, low toxicity. Grade 3 is represented by boxes, and there's only 1 patient with grade 3 toxicity, some patients with no toxicity at all, and others with most patients that developed toxicity, it was grade 1 or grade 2. And as you can see here, very low risk for toxicity, both acute and late. So some take-home points are that although modern surgery and preoperative treatment have reduced the risk for local recurrence, it is still about 20%. And re-irradiation with conventional techniques necessitates hyperfractionation due to risk for toxicity. However, that risk for toxicity is still about 30 to 50%, and local control at 1 to 2 years is only about 50%, certainly suboptimal. IMRT or protons can help reduce that risk for toxicity to bring it down to about 1/3. And the challenge with LDR interstitial brachytherapy is that it is limited to centers that are high volume and have experience in this procedure. And so SBRT kind of represents the next frontier, improves local control from 50% to 70 to 80%, significant reduction in toxicity, especially of late toxicity. And the question remains whether low dose elective volume to reduce the risk for local regional control is important. And what about combining SBRT with surgery, kind of like the MD Anderson folks did with hyperfractionated radiotherapy? So I just want to share a quick case of our approach that we've been utilizing in select patients after discussion in Multidisciplinary Tumor Board. This is a lady of mine, 39-year-old young lady who had TNT, adenoma, and an APR, and unfortunately developed a right pelvic sidewall recurrence. She was started on FOLFOXIRI and Avastin chemotherapy, and prior to planned surgical resection because of concern for right lateral sidewall margin, we did SBRT. And what you'll notice here is that the SBRT dose was much higher than the European study. We treated to 40 gray, and parts of it were receiving 48 gray, all in 5 treatments, especially in that obturator internus, where the risk for positive margin would be. And so this patient subsequently underwent a XLAP, and the frozen pathology showed concern for positive margin. So I also did intraoperative radiotherapy. And when the final pathology came back, you'll see highlighted here, the patient had actually achieved a complete response to her tumor. And this patient had a biopsy prior to initiation of re-irradiation. And so a pretty spectacular response. And so with that, I will conclude my presentation. I'd be happy to take some questions when the time comes.
Wonderful. Thank you so much, Dr. Balagamwala. We'll save questions for the end for the case discussion. Dr. Balagamwala, I think you highlighted the really good case, and we have some cases at the end of the webinar today that illustrate how we basically how we make decisions for who needs preoperative re-irradiation, how do we decide between these various techniques, including more complicated ones like SBRT. One of the things that I really struggle with in our multidisciplinary tumor board is this competing risk of distant recurrence, either prior to these local therapies or afterwards, particularly because re-irradiation, surgery, there's a lot of morbidity associated with them, as you showed from the MD Anderson trial. So our next speaker will be Dr. Mark Shapiro, who's staff in the Department of Hematology and Medical Oncology here at the Cleveland Clinic. He completed his residency at Emory and his fellowship at Fox Chase Cancer Center. You know, a lot of the speakers today and much of what we discussed in our tumor board focuses on the local aspect of locally recurrent rectal cancer, but there's really not much data in terms of post-operative or neoadjuvant induction systemic therapy, especially in this patient population that has this high competing risk of distant recurrence. So I'll introduce Dr. Mark Shapiro, who's going to be discussing perioperative chemotherapy, an area of contention for locally recurrent rectal tumors. Thank you, Dr. Shapiro.
Thank you, Jacob. Thank you so much. You know, one of the basic principles of all of this is a multidisciplinary tumor board. And I have to say that our colorectal surgery tumor board, our colorectal tumor board is probably one of the best that we have in the system. And it's really been an honor and a highlight of my career and taught me a lot about how to approach this. I think the biggest service I can provide tonight is to remind myself, remind the medical oncologists of the role and the limitations that we have in these situations. I think even there's a lot of nuance to these scenarios. Core oncologic principles still drive our decisions, and I think we have to stick to our principles. And a lot of my theme for tonight is a few words of caution. And we remember that we really have two boxes. There are two areas that we think about, that I think about. Certainly, we think about local control. This is a local recurrence issue, and this is what demands our attention. As a medical oncologist, as Jacob said, I'm thinking about systemic micrometastatic control, and there are two ways that we really go about doing this. But I think we have to ask, what are we asking our chemotherapy to accomplish? And of course, in these situations with local recurrence, the primary goal here is an R0 resection. This is the foundation of treatment. And the ability to do this is certainly driven by the initial resectability, determined by the expertise of our radiologists and, of course, of our surgeons. Of course, they're often asking for help. And the main support for obtaining an R0 resection is going to be with radiation, downstaging perhaps, cleaning up any local micrometastatic disease that we know patients are at significant risk for. And so radiation is the driver of this control, is the driver of downstaging. And as we do in the de novo situation, chemotherapy is here to sensitize the tumor to the effects of the radiation. And we're using the same traditional doses of Xeloda and 5-FU that we're doing when we're doing chemotherapy and radiation. And for the majority of the time, this is what I'm asked to do, is to sensitize the radiation and hand things over to the surgeons. There are situations, of course, when these tumors are borderline resectable or sometimes seemingly unresectable. And these are occasional scenarios where it's more advanced in the rectum but has not metastasized. And I am asked as a medical oncologist to optimize response beyond what radiation can accomplish. Usually in these situations, there's low optimism for conversion. And so most of what I'm thinking is going to be in the palliative setting with the hope that we get some response where we can get lucky and transition to a curative intent resection. But what I often keep in mind is caution against overuse of my drugs, and most importantly, the complications of our biologic agents and the toxicities that they have. And the biggest one that I always think about is bevacizumab. As we've learned very quickly with wound healing, with bowel perforation, with bleeding, this drug has significant toxicities that can be catastrophic. And the last thing I want to do is cause complications to an already difficult surgery, cause catastrophic complications in a pelvis that's already symptomatic. And even if the drug is held 6 to 10 weeks preoperatively, there is a significant chance of wound dehiscence, of anastomotic leak, sometimes up to 15%. And so I'm very cautious about using Avastin. I admit I have caused a situation of fistulization, rectovaginal fistula, and the biggest risk for this is an intact primary, especially if there's a T4 lesion invading the bladder, invading the vagina, or in tumors that are to be radiated or have been radiated. We know that the baseline risk for perforation in the bowel is 4%. I think that in case series, we're looking at least at double-digit risk. And once you get into this situation, it is very hard to salvage. And so essentially, if I have an intact primary, I essentially don't use Avastin because that's the last thing I want to cause. I think we also have to be cautious with EGFR monoclonal antibodies. And one of the biggest trials that comes to my mind was the new EPOCH trial in patients with liver metastases, so a different scenario. But I think it teaches us a lot about what we don't know about the use of EGFR monoclonal antibodies. I'm always reminded when I was a fellow and we were testing immunohistochemistry for EGFR, even though we knew that wasn't the right answer and we quickly moved on to KRAS, is that we don't really know what the biomarkers are. So this was a trial that took patients with colorectal cancer with resectable liver metastases. They were all KRAS wild type soon after they changed the protocol. Perioperative systemic chemotherapy. Patients received 3 months pre and post-op with chemotherapy plus or minus cetuximab. Those patients who received cetuximab did worse even though they were RAS wild type, decreased performance, progression-free survival, a significant decrease in overall survival. There was a concern that we were causing accelerated recurrence, and you can see in the hazard ratio for overall survival that this happens very quickly, that we may be accelerating an aggressive phenotype. And so even though we've learned a lot about biomarkers, I think it still remains elusive as to who really benefits in the micrometastatic setting. These were patients who were upfront resectable. We have to remember that most of these patients who have local recurrence have seen previous therapy besides surgery alone. Certainly now, the majority of our patients are getting total neoadjuvant therapy. They're receiving long course radiation with radiosensitizing Xeloda, and they're getting 4 full months of FOLFOX and or Xeloda. So these are tumors, these are cells that have already seen significant chemotherapy, including the micrometastatic disease that we may have out there. And there's consistent benefits, there's consistent data over the decades that shows limited benefit from micrometastatic control and increasing cure over time. We reach way back to the 90s when we learned from Intergroup 89 that 6 months of 5-FU was as good at 12 months in terms of cure rates. We've learned more recently from the IDEA collaboration that 6 months is non-inferior to 3 months of Xeloda. And of course, we know that Avastin and EGFR monoclonal antibodies have no adjuvant benefit. So when we have a local recurrence, my job is for local control and getting people to surgery. And so I'm very cautious not to be tempted to go beyond 4 to 6 months of full dose chemotherapy, including whatever they had at the initial time of diagnosis. And I essentially limit my role as much as I can. I'm here for radiosensitization. Our goal is to get an R0 resection. I'm super cautious about Avastin so that I don't cause a catastrophic toxicity either pre-surgery or post-op with a leak or dehiscence. If I have to, I use chemotherapy for downstaging, but often when I'm asked to do this, we're transitioning to palliative intent pretty soon after. And so then I'm treating folks just like as I always do with metastatic disease, again, except for caution with Avastin.
And I have the pleasure to introduce our next speaker. Dr. Ed Reese is the chair of the plastic surgery department here at Cleveland Clinic, Maine. He joined us recently from Mayo Clinic. His surgical training was in Texas at UT Southwestern for his residency, and then he went to San Antonio for his hand fellowship. He has a special interest in plastic and hand and spinoplastic reconstructive surgery. We often involve our plastic surgery colleagues when we are involved in doing resections for these recurrent rectal cancers that result in very large defects that are difficult to fill, difficult to heal. And so we're really excited to have him speak to us about reconstructive options in these cases.
Thank you for the nice introduction, Dr. Chung. Thank you, Dr. Miller, Dr. Liska, esteemed colleagues. It's my pleasure and honor to talk to you today about reconstructing recurrent resection defects from a plastic surgery standpoint. One of the things that I think I would just like to underline is the role of plastic surgery. These are cases that your average plastic surgeon absolutely loves to get involved with. And at the Cleveland Clinic, we feel even stronger about that because we want to allow our colorectal surgery teams and the multidisciplinary teams to go further than they thought they could in terms of resection. Next slide, please. In general, we come in to try to patch things up. And what we have to think about is how will the patient's quality of life be affected after the resection? When they're hopefully as cancer-free as possible or completely cancer-free, can they maintain their functionality? Can they sit? Can they be in a pain-free reconstruction in a sitting position? Can they move around? Is continence maintained? Is that even possible? What would that look like? How do we minimize the donor site complications and morbidities? Oftentimes in plastic surgery, we have to rob Peter to pay Paul from different parts of the body. And we want to minimize this in a way that allows maximal functionality. We also want to have predictable results. We've heard about possible complications with chemotherapy, radiation therapy, also things like physiologic state of the patient or comorbidities. All these come together for how we choose reconstructive options. And we try to dial that in to help the patients the most and allow complications to be minimized. And of course, at the end, we wouldn't be plastic surgeons if we didn't try to provide the best aesthetic results possible. Not always the mainstay, but this is something that we constantly think about because people have to go on with their lives, and this can completely change their lives. Next slide, please. In thinking about the resection and then therefore what we have to do for the reconstruction, the muscles that are taken or thought to be taken or the bony structures that have to be removed are critical when we're thinking about this in our tumor boards and in preoperatively, whether this involves anal rectal triangle and the ischial fossa, whether it involves the sacrum. How can we maximize the resection and still maintain the best quality of life for the patient in a reconstruction that makes sense and decreases morbidity? And often the GU tract is involved in these things, which has to be considered in the reconstruction. Next slide, please. There are often many vital structures at risk, and our job is to repair those in such a way that the colorectal surgeons, the orthopedic surgeons, the spine surgeons who are doing the resection can not worry about what it is they're removing, that it actually can be addressed and minimized in terms of impact of nerves and blood vessels in these areas. And in fact, we try to use the nerves and the blood vessels themselves to aid in our reconstruction, which keeps advancing the field from a plastic surgery and reconstructive standpoint as to how we can best help these patients. And there's a lot down there, a lot of high-priced real estate, as we all know. Next slide, please. So the defect size does matter. And in thinking about these, we are very careful as plastic surgeons in tumor board when the resection is considered to be a certain size. In the back of our minds, we always think, well, after frozen section, trying to get more margins, what could this actually be? And in doing so, we come up with an algorithm that delivers the tissue and the amount of tissue and the type of tissues in different areas based on the location in the anorectal triangle or where the local recurrence is, and what that will mean to the patient in their lives. You see here a small, medium, large, and sort of medium algorithm. And this is a general predictability so that we can consistently come to the table knowing in general what we'll offer. However, as some of you have seen in working with your plastic surgeons, this can actually become a much larger issue to deal with if the size increases or the type of tissue, whether it be bone, vessels, or nerves, become involved, requiring a more complicated reconstruction, all the way up the ladder to free bone reconstruction, soft tissue reconstruction, using free tissue transfers. Next slide, please. We have a myriad of reconstructions, and one of the reasons that people like me go into plastic surgery is the creativity that can be brought to solving reconstructive problems, whether that be using posterior thigh flaps, gluteal muscle flaps, VRAMs, which is a very constant workhorse for us, whether it be gracilis muscles, Singapore flaps, or actually moving local pedicle vascularized bone grafts or free vascularized bone grafts from other parts of the body. We want our surgeons freed from the shackles of worrying about what the defect will be left with so that they can focus on solely removing the cancer. If we can provide that and push our surgeons to allow the best chance for survival and cancer resection, we feel like we have done our job. And that is one of our ethos at Cleveland Clinic, to serve the most complicated patients, and especially with local recurrence, how we can best deliver results to these patients. Next paragraph. Excuse me, next slide. So it's all about the location of where the resection is and where the resection goes in terms of frozen section. And in considering these, you have to allow your plastic surgeon the freedom to take tissue from different areas of the body, and that can include variations in positioning, changes in position during surgery, and of course, possibly bringing in microscopes and so forth so that we can reconstruct the areas that are brought from very large defects that could potentially involve many different tissue types, from the GI tract itself to the local muscle, to the regional muscle, and to the bone, from a sacrectomy to a hemipelvectomy. All of these are potentials that we want to give the patient the best chance of being cancer-free. Next slide, please. Our reconstructive options are growing. In fact, every day we have new techniques. We are applying robotic techniques now to match our colorectal surgery colleagues' robotic skills to minimize incisions for our patients, and to potentially bring in muscles such as the VRAM without having to make an abdominal incision. We want the idea of irresectability from our standpoint of what we'll do afterwards to not be a concern at all for our colorectal team and our multidisciplinary team. So we ask that you consider us for consultation from plastic surgery, because this gives us an opportunity to really help impact the patient's quality of life. Next slide, please. Our key takeaways for considering the plastic surgery reconstruction when bringing the plastic surgeon onto the team for a multidisciplinary approach for management of local recurrent rectal cancer are that there are many techniques. So we ask that our colleagues don't assume that something might not be able to be dealt with and therefore irresectable, but that the consultation may be made so that we can assist in this decision making. We want unimaginable outcomes that are good and positive for our patients, and we want to allow our colorectal colleagues and our multidisciplinary teams to go further than they ever thought was possible in resecting these tumors. And we want an excellent quality of life, which in many cases we can deliver while minimizing morbidities. Next slide. That is a summary and a thumbnail sketch of what plastic surgery can offer. I thank you all for your attention, and thank you, Dr. Chung, for allowing me to speak tonight.
Thank you so much. That was excellent, and being able to, really be able to expand our ability to offer, especially as we're getting younger and younger patients with aggressive cancers presenting to us with, I've been being told at other places that operative option is off the table. Being able to give hope and a chance at cure for those patients, or even palliation, it really makes a huge difference. Please feel free to send or type in questions that you may have for our panelists in the chat box, and we can bring the rest of the panelists on screen. While we do that, and I'll invite Dr. Miller to pull up our cases, and we can go over some of those.
Thank you. I think, Tim, yes, thank you so much for pulling up the cases. So we've prepared a few cases that illustrate some of the topics that we've discussed. Again, if there's any questions along the way, please feel free to add them to the chat. So next slide, please. Next slide. So these are, the first two cases are both patients that I took care of that we discussed in our multidisciplinary tumor board, patients that ultimately underwent resection. But this is a common story that we get, patients who were referred from outside hospitals looking for second opinions or input regarding resectability. So this is a 45-year-old that I took care of who was originally diagnosed with a T3B/N2 microsatellite stable midrectal tumor. He had been treated with total neoadjuvant therapy, including long course chemoradiation, FOLFOX. He underwent a margin negative low anterior resection, diverting loop ileostomy, and ended up having a reversal, and then proceeded with standard surveillance and was doing fine. 2 years later, he had elevation in his CEA, and imaging was obtained that showed a small asymptomatic presacral recurrence, and it was tethering the left ureter, it was abutting and encasing the left internal iliac artery. And at his local oncology team had deemed him borderline or unresectable and had started the patient on FOLFOXIRI panitumumab. Before we maybe talk about resectability and surgical technique and radiation, et cetera, I wanted to get Dr. Shapiro's thoughts. We often meet a lot of patients where the decision for systemic therapy has already been made for us, induction or palliation. When you have patients who you meet in clinic with locally recurrent rectal cancers who may have already been started on likely palliative intense systemic therapy, and we're evaluating them on our tumor board, how do you counsel patients make decisions? If they've already started systemic therapy, do you advise them to continue it for a period of time? How do you think about the goals in caring for this patient population when they've already been started on, in this case, an EGFR inhibitor that you sort of discussed, as well as an irinotecan-based regimen?
Yeah, so it's not unusual for these patients to come to me first, who have, self-referred themselves for an opinion. And what I do is I very quickly present them to tumor board, so that I can get a sense from the surgeons, from the radiation oncologists, as to what's possible for plastic surgery, so that I know again what I'm trying to accomplish, what I'm trying to ask of the chemotherapy. Very rarely has the bridge been burned by the chemotherapy. I think I brought up Avastin because I'm personally traumatized from things that have happened to me in the past and things that I see on occasion. And so I think the key is very quickly getting consensus from the tumor board as to what we're trying to ask our treatments to accomplish.
So thank you very much. One of the challenges, I think, as a radiation oncologist is understanding what is resectable. And I welcome Dr. Reese's opinion, Dr. Liska, Dr. Chung. When I see a patient like this, we sometimes care for patients with pancreas tumors, and we We look very closely at arterial anatomy and venous anatomy. And something I've been really impressed by in our multidisciplinary team is just the limits of what can be resected. So this tumor was abutting or encasing left internal iliac. Perhaps Dr. Liska or Dr. Chung, are these patients always unresectable? Are there considerations for who you would entertain the idea of a surgical resection when they have pelvic sidewall involvement or arterial involvement?
Yeah, I think a lot of it depends on the size and where along the vessel the involvement is. Usually veins can be taken, and I know Dr. Liska recently had a case where there was both artery and vein involvement, and he managed to resect that, and with the help of our vascular surgery colleagues. So in well-selected patients with who are going to tolerate, obviously people with peripheral vascular disease, you got to be careful about what you do in terms of the vascular reconstruction options there are. But many times we can have our vascular surgery colleagues comment preoperatively on what they think is doable, and then help us in the operation. Dr. Liska, do you want to talk a little bit about your recent case?
Yeah, for sure. So, for the internal iliac vessels, right, those typically we think can be sacrificed freely, and for the iliac artery and vein, obviously having control of them intraoperatively early on before getting too close to where the tumor is involving them is critical, so you don't get into horrible bleeding. But we can take the internal iliac vessels usually without requiring any reconstructions. The external vessels, those are the ones that Dr. Chung just mentioned, is where we do have to, if we resect those, we obviously need to reconstruct them, and those are the cases where definitely you need to have very close conversations with the vascular surgeons in terms of what Dr. Chung mentioned, the size of the tumor, how much of the vessel is involved, and can it be reconstructed safely? What type of reconstructions options do you want to choose? So yeah, like Dr. Chung mentioned, we did have a case. It was more of an upper tumor, a sigmoid tumor that was involving the internal iliac vessels, and that patient got chemo and radiation ahead of time. It was a perforated tumor, and we did reconstruct the artery and vein. The artery was reconstructed with a bovine pericardium patch, a graft, a tubular graft, and the vein with a patch, and that can be done. Again, it's critical to preoperatively have that plan. You don't want to sort of intraoperatively start sort of scrambling for that, and preoperatively discussing with the vascular surgeon so that it is actually doable, because you don't want to go in and with a plan for a curative intent resection and then being faced with something that's not resectable.
I've also encountered situations where we go in thinking that we're going to need to do some sort of big vascular reconstruction based on imaging, but we're able to peel the tumor off, like for instance the side surface of the artery. So that leads to my question to Dr. Balagamwala and maybe Dr. Miller too. The role of intraoperative radiation, when is that something that we should be thinking about? What is the effectiveness of it? And could you speak to us about your experience with that?
Certainly. Maybe I'll let Dr. Balagamwala comment on it.
Yeah, of course. And so intraoperative radiation is a unique kind of a treatment modality. It's best, depending on the treatment modality, the type of IORT device that one has available. We have a device that's available that delivers 50 kV X-rays, and so it is very superficial. So if it's truly a positive margin within 5 millimeters and a small margin, we can treat that pretty adequately. However, if it's like a diffuse positive margin, deeper, and unable to get the applicator close to it or in contact with it, then the effectiveness goes down. and it can go down significantly. And so when we're placing it, and I know Jacob does this as well, we actually scrub in and ensure that, we discuss with the surgeon where that positive margin is, and physically verify if the surgeon's placing it or if we're placing it, depending on the case, that there is direct contact. In terms of, outcomes, it's variable depending on the study that you look at, and very hard to tease out whether IORT is truly making a difference or not. And that's been the primary impetus for us to develop the preoperative SBRT program, where we can deliver a high dose to that concerning margin, so that even if it is positive, we have preoperatively ablated it, and so thereby reducing that risk for recurrence significantly.
And I agree. I think one of the themes of locally recurrent rectal cancer is it's really challenging disease to study. To my knowledge, there's no randomized trials. The highest quality data that we have are single-arm phase 2 studies telling us a little bit about how radiation works. So we really go back to first principles. There was in terms of effectiveness, there was a combined analysis between Mayo and a hospital in the Netherlands that did suggest that the addition of intraoperative electron radiotherapy had a benefit for local control. But it probably does increase the risk of nerve injury, so sacroplexopathy, as well as wound complications, as well as prolonging surgical time, and these are already very complex surgeries. For this patient, I actually discussed them with Dr. Balagamwala. When I was trained, I treated a lot of patients with hyperfractionated re-irradiation, similar to the MD Anderson experience. And for context, for the non-radiation oncologist, it's a relatively low dose of radiation that we're using because of that prior radiation dose and our concerns about hurting radiosensitive bowel and other structures. Dr. Balagamwala, for this patient, we had discussed them in tumor board. It was obviously a budding encasing left internal iliac. I had a high concern for a positive margin if the patient went straight to surgery after systemic therapy. So I recommended preoperative external beam re-irradiation and talked about a couple different techniques. Compared to the standard, which I would say is hyperfractionated re-irradiation and low dosage, how do you think about selecting patients for an SBRT approach, this high dose, much more focused, versus a conventional fractionated approach?
I fully agree. Hyperfractionated radiation is certainly standard. And that's the first thing I discuss with my patients as well, because we have the longest data supporting that. SBRT is emerging and evolving. The way I, kind of think about selecting the right patient for SBRT, I think conventionally, hyperfractionated basically can do it in anyone that's, either going to surgery or even if they're not going to surgery for palliation. When it comes to SBRT, one has to choose a little bit carefully. I tend to favor it, especially for presacral or lateral pelvic sidewall recurrences, where the positive margin is either going to be in that presacral fascia or the muscle. If there's bowel nearby or ureter, or I don't worry too much about the blood vessels. The blood vessels handle radiation a little bit better. But bowel is my biggest concern. And if there's going to be an area that is not going to be resectable, that's where I tend to favor SBRT, where I can deliver a little bit higher radiation dose to ablate that margin.
Thank you very much. Next slide. Yeah, so in this patient, I kind of discussed both options. The tumor was the recurrence was relatively small, involving the internal iliac, as I mentioned, and it was touching but not circumferentially invading the colonic conduit. So I recommended SBRT. I felt that especially if the surgeons had difficulty getting the tumor out, delivering a more ablative dose would be helpful. So I treated the patient with 5 fractions of SBRT to 40 gray. As you can see here, this is the patient's SBRT radiation plan. Something that Dr. Balagamwala discussed was we often use an elective or lower dose volume to areas that we think are at risk. And some of the structures on this radiation plan that you're looking at and highlighted in green is the small bowel. So we're very mindful to protect that because it's one of the most radiosensitive structures, and radiation in the de novo setting puts patients at risk of chronic enteritis and small bowel adhesions and blockages, but we certainly worry about that. So this is their patient's radiation plan, and we're also careful to protect the nerves. The patient then underwent a robotic assisted APR, resection of the left internal iliac artery, left pelvic sidewall, reimplant of the left ureter, on block resection of the anastomosis, and they did have IORT because we're concerned about that lateral pelvic sidewall margin. Next slide. Pathology showed residual disease, so T3N1A with EMVI, perineural invasion. There was some treatment effect. Margins were negative but close. Unfortunately, long-term follow-up, the patient did develop a liver metastasis 14 months later, just again highlighting this high competing risk of distant recurrence, but they haven't had any evidence of pelvic recurrence after 36 months. Dr. Shapiro is kind of illustrating this disease that has a high risk of local recurrence. This patient ended up having a distant metastasis. Is there any patient, if you kind of meet them after they recover from their surgery, where you're recommending adjuvant chemotherapy or doing any type of ctDNA testing if they've had a close margin or perhaps residual nodal disease, or do you proceed with close surveillance?
Yeah, so we're only as good as the chemo we have. We're only as good as the tools that we have. And we have to be honest with ourselves and with our patients what we think we're going to accomplish for them because of the toxicity. For many patients, this is important time, and the chemotherapy gets in the way of them being able to live their lives. Certainly, if they did not get any systemic chemotherapy previously for previous disease, I'm going to give them a full 6 months of full FOX if disease has not been exposed to full dose. So I'm serious about that. And I think we do have an impact. I think in a situation where there's a high risk, but those cells have already been exposed to 4-6 months of 5-FU and oxaliplatin, we can delay progression. Whether or not that translates into overall survival, I think is really questionable. And so even if there's positive tumor DNA, I'm hesitant. And then I start running into the problem is, what am I using to measure success? Because if I don't have anything radiographically, now I'm going for a significant period of time between when those cells are progressing and when I actually know it.
Very well
Certainly
said.
can't put them on trial without evidence of disease.
Yeah. Very well said. Before we go on to our next case, any additional comments from either the panelists or questions from the audience?
Yeah, I think for these patients that recur, distally, that's always obviously extremely sad and frustrating, right? Where we put all that work in to get the local disease under control, and it seems like we were successful, and then be foiled by that. So I think typically the interval between, when something pops up is very important to look at. If somebody had a very short interval of being disease-free, you probably don't know that it's only localized disease. In this case here, it seemed like there was a long interval, and even when the liver mets popped up, it was quite a long time after the resection. So I think everything was done the right way, but in many of these cases, I think the decision about giving more chemo also is sometimes just to let the disease declare itself and kind of figure out where we are in the disease course, so we don't have the patient undergo very morbid treatments while they're still having sort of evolution of the distant disease.
Thank you. So we'll go on to our next case. Similar situation, but different extent of disease when we met this patient in our multidisciplinary clinic, but also a different disease course, much more indolent, sort of analogous to what Dr. Lisk was discussing, and a really challenging situation that we sometimes encounter. So this is a 60-year-old who was originally diagnosed with de novo oligometastatic disease, so microsatellite stable rectal cancer, and she had undergone chemoradiation, resection of the liver metastases, so this was prior to TNT being standard, pelvic chemoradiation, resection of the liver mets, LAR, DLI, adjuvant FOLFOX, DLI closure, and was disease-free for 5 years. Potentially cured, but 5 years later, at her last surveillance imaging, she was found to have a presacral and left lateral pelvic sidewall recurrence. This was again involving the iliac vessels, but in this case, a little bit larger than the prior case. So tumor was larger, it was involving and tethering more small bowel, it was involving the posterior aspect of the vagina, and there was a synchronous right lower lobe metastasis that was biopsy proven. Similar to the prior case, the patient had been started on palliative systemic therapy, including Avastin, and sought a surgical opinion. Maybe Dr. Shapiro, again, it's kind of interesting in patients who have de novo oligometastatic disease, we manage them quite aggressively and resect their metastases. In the situation where we have a patient with 2 sites of disease, she had gone 5 years after her initial diagnosis without distant recurrence. In a patient like this, would you ever consider aggressive local therapy, or should this patient maybe remain on systemic therapy alone with the synchronous lung met?
Yeah, so the biology is going to drive our results, and clearly this patient has a different biology than our average cancer. Most of these recurrences are going to happen within the first 3 years. It's pretty unusual this far out. I think that there's a role for removing what you can see. I think we always have to remember that there's biology out there that we don't see. And I think we have to remember that, this is disease that hasn't seen chemotherapy for a while, but this is also disease that saw this chemotherapy. And so certainly I can't cure this without a surgeon and or a radiation doctor. And I think, obviously anybody that walks into our office, the question is cure. And it comes back to those basic principles. If I'm told that it's unresectable, then I'm going to continue as I otherwise would. I'm always going to keep the surgeons in mind and keep them in the loop. But I think I circle back to the same principles.
Yeah, it's really challenging. So she was symptomatic, so she was experiencing pain in the pelvis as well as toxicity from her systemic therapy, and really motivated to pursue aggressive treatment after extensive counseling. Next slide. So she was reviewed in our multidisciplinary tumor board. Her disease in the pelvis was felt to be borderline resectable. She was experiencing considerable side effects from her systemic therapy and needed a break. So she underwent SBRT to the right lower lobe and hyperfractionated pelvic radiation. With concurrent Xeloda. We instead of SBRT for this patient, because of the extent of small bowel adhesions, we utilized a more traditional approach of hyperfractionated radiation, and she did have relief of her pelvic pain. She had restaging imaging. She actually had a longer interval where she was monitored to make sure she didn't develop new metastatic disease, and she was again followed in our tumor board, and the question remained, should she undergo a resection? Next slide. I wanted to take this opportunity to talk about some of the toxicities of re-irradiation. So Dr. Balagamwala, this was, we were able to obtain her outside radiation plan, which is on the bottom here, on the axial, sagittal, and coronal images. She, as I mentioned, had IMRT, VMAT, re-irradiation, which is the middle panel, and then the top is the cumulative dose of the different structures, and you can see that the dose is there. So when you meet patients, irrespective of what their disease status is, but when you're considering re-irradiation, how do you counsel them about the associated risks, and what structures are you looking at when thinking about cumulative toxicity?
Yeah, that's a really important question. We spend a lot of time talking about that in our clinics. Certainly, you can see in that bottom panel with conventional 3D conformal radiotherapy, a lot of the normal tissue is getting radiated from the bones, the sacrum, the pelvic bones, but also all the nerves, and the bowel. And so the major toxicities that we want to talk about is certainly the bowel toxicities in terms of enteritis. Patients can be at risk for cystitis as well. And you nicely shown in your previous case the importance of contouring out and delineating the sacral plexus. That's not only important from the IORT perspective, but also in the re-irradiation setting. And certainly the risk for insufficiency, pelvic fractures also goes up. When we approach doses, cumulative doses of 80 to 90 Gray, it's certainly elevated as well.
Thank you very much.
And one of the other, if I may, a couple, gender-specific toxicities. So for women, talking about vaginal stenosis is really important. And sexual dysfunction with vaginal dryness. But in men also, there can be a risk for erectile dysfunction, especially when combined with surgical resection, if a partial or a total prostatectomy is involved in this resection as well. And so those are important things to kind of talk about so that the patients are aware what they're getting themselves into.
Thank you. So next slide, please. So she was off systemic therapy, monitored for a while with imaging, didn't develop any disease progression, and did have palliation from the radiation. Ultimately, after extensive counseling, she underwent surgical resection. So she underwent APR, partial cystectomy, upper vaginectomy, an ileal conduit, intraoperative radiation to the left pelvic sidewall margin. She had an omental pedicle flap in this case, and then her final margins were negative. Perhaps talking a little bit about reconstruction options, Dr. Reese, for the prior patient or this patient who undergo extensive resections for lateral pelvic sidewall recurrences, if the internal iliac artery has to be sacrificed, does that impact your reconstruction options at all, or any considerations for your surgical planning?
Thank you for that question, Dr. Miller. It's a double-edged sword. Certainly from local options, if the iliac artery is taken, your ability to use some of the gluteal flaps, some of the flaps that would be local or can be limited. From the opposite side, obviously that can still work, but the benefit of it does allow you very immediate access for free tissue transfer for bringing in more regional and distant tissue to solve some of these problems. A mental flap in this particular case is a good option because with all of the therapies that have been introduced here, including resection and radiotherapy, scarring on this area, as was mentioned, is a real problem. Omentum can help that somewhat. One of the things to consider potentially in the future is when you're dealing with a partial vaginectomy, the omental flap will not help with that reconstruction. And in that setting, you could see even worse vaginal stenosis, for instance. Whereas this coupled with potentially a muscle flap, for instance, something from the gracilis muscles, it could be possible. This was not my case, so I would not make any criticisms other than the considerations. When you're this close to the nerves as well, you want to make sure that there is some sort of soft tissue protection or covering. Omentum does a great job with that, with vascularized fat. And depending on the size of this, obviously taking something like an anterolateral thigh flap or something VRAM, although my imagination here says that the patient had previously been diverted. So that obviously limits us quite a bit as what we can do from the abdomen standpoint. But looking at an iliac artery and then having the ability to take something like an angulated thigh flap, possibly even some muscle that can be reinnervated to help with vaginal reconstruction. These are some options that can help the patient with quality of life. But we have to remember, all of us, when we're doing this, we want to be part of the 4-2 club. We want to do surgery for the patient and not just to the patient, because any of these things can be resected. But what will be left with this, if half the sacral plexus on that side is removed, for instance, if there's essentially no sciatic function, or even just from the standpoint of sensation, all these things are really need to be considered in the reconstruction option.
Thank you very much. So I think, so this patient, she did not develop a local recurrence. She did ultimately, months later, develop a new lung metastasis, which was subsequently treated. Otherwise, she's doing well. We'll skip ahead a couple of slides to the next case in the interest of time. Okay, and then I'll have Dr. Chung present.
Yeah, this will be more of a tumor board style case because we have not actually treated this case yet. So I'm interested to see kind of what we come up with here as a team. This was a 61-year-old male with a history of T3N1 rectal cancer, status post, had an LAR many years ago. He had adjuvant chemoradiation, interestingly, and his course was then complicated by an anastomotic leak that turned into a chronic sort of situation, and that was treated non-operatively with the use of antibiotics and drains. Next slide. He presented 2-3 years ago. It's unclear how much surveillance he had. But he presented with bloating and pain, and these were some representative images from his imaging. There was, on the left, you see a little bit of fibrinous exudate there where there was that known defect in his anastomosis, and on the right, some stenosis seen kind of in his rectum and his above his anastomosis. Next slide. Next slide. So at the time of his representation, they did take some biopsies for concern of malignant stricture, and that was negative. He represented later that year with bloating and pain, and symptoms were attributed to chronic contained anastomotic leak. This is his MRI from that time. So in this setting where known anastomotic leak, these were biopsied negative. We're thinking this is probably not malignant based on tissue, but obviously with the history of an anastomotic leak and the way that looks on MRI, you know, the concern is for potential recurrence. Next slide. He was admitted, and then his obstruction symptoms became intractable, and so we had to do some sort of operation for him. So at this point, I'd like to ask Dr. Reese, like, here's a patient who we don't have documented evidence of recurrence, but obviously we're keeping that in the back of our minds. And he's had a previous LAR, and as you mentioned, a right-sided ileostomy that kind of precludes that rectus on that right side for potential future flaps. Is this someone that we need to be thinking about in terms of, all right, we need to do something for this guy, needs to be diverted for this bowel obstruction? Should we be thinking about reconstructive options at this point and being mindful to try to save that untouched rectus? I know that comes up a lot when we talk about reconstruction down the line, but What are your thoughts on that? Like, is that a practice that we should be adopting as colorectal surgeons?
Thank you for that question. I think we would be remiss if we didn't, simply because if this proves itself to be a recurrent cancer, we've burned one of our largest reconstructive options. So if there is a way to preserve that rectus on the opposite side, I think it behooves us to try. It will, in the long term, potentially help the patient if we do, in fact, need to use it. So I think asking that question up front, sometimes obviously it's not possible, but if there is an opportunity to do so, I think we should look at that option.
Yeah, thanks. Next slide. So the patient did end up going to the operating room, and they actually were forward-thinking surgeons and did an end ileostomy utilizing that right rectus. He did okay for a couple more years and then re-presented with this MRI and worsening pelvic pain and imaging that suggests bladder issues, and he had some retention. Next slide. And so he had a repeat flexible sigmoidoscopy, and biopsies did confirm mucinous adenocarcinoma. So I want to sort of open up the discussion to involve Dr. Balgamwala first. I think that's kind of going to be our first question is, obviously looking at this large mass invading the sacrum and possibly likely the nerves that are the sacral nerves. What are some radiation options here?
Very, very challenging case. Yeah, very interesting as well. Mucinous adenocarcinomas I'm really scared of them. They tend to recur a lot. They don't tend to respond as well to radiotherapy either. And Dr. Shapiro can comment on chemotherapy response. But they just don't tend to be very responsive. And so I love surgery for them. And as you were speaking, the slow growing nature of this, I was wondering when you're going to say it's a mucinous cancer. And so in terms of radiation therapy, given that it's invading S3, S4, possibly S5 there, looks like S2 as well, it's likely going to be unresectable. And so the option really is palliative control so that this patient's pain is minimized and can maintain mobility in the lower extremities for as long as possible. And then, certainly the bladder cannot be forgotten either. And so in these situations, one can consider either conventional palliation of 20 to 25 gray in 5 fractions, or consider SBRT or radiosurgery. One of the other hats that I wear is I do a lot of palliative CNS, and so spine radiosurgery is one of my other interests, and we have taken care of a fair number of patients with sarcomas in the sacral spine that are very radioresistant, that we do high doses of radiotherapy utilizing similar principles as SBRT, but call it radiosurgery to try to control them. And we've had a fair bit of luck achieving that control. And so in these cases, I favor, certainly involving the colorectal surgeons, but also involving my colleagues in neurosurgery and spine surgery to help with this and treat it with radiosurgical principles.
That's great. Dr. Shapiro, any role for chemotherapy here?
Yeah, so certainly the first thing on my mind is to get a full NGS panel. It's been quite some time since the patient had cancer. And so we want to make sure that we know as much about this biology as possible. Certainly mismatch repair proficiency or deficiency is going to be first on my list. I think if the surgeons say this is potentially resectable or potentially one day resectable, I'm going to try and get as much response as I can. I think most of our response is going to happen within the first 3 months. And so we're going to know quickly. This is not something that's going to drag out forever in terms of what I can accomplish. If this patient is RAS wild type, BRAF wild type, I'm going to use a biologic. I'm going to use a monoclonal antibody because this is our chance to try and cure this cancer if we can get a response.
Yeah.
So I'm willing to go aggressive, but we're going to find out pretty quickly whether or not that's possible.
That's really helpful. So let's remain optimistic, and let's say 3 months from now, he's gotten all his treatment and he has some response and he becomes deemed resectable. Obviously, this is going to involve, as you mentioned, spine surgery, us, urology. After doing such a huge multivisceral resection, what would be your reconstruction of choice for a case like this, Dr. Reese?
Sure. Thank you very much. I think that a portion of the sacrum is going to be removed here, if not all of it. And if you're talking about S1, S2, and the stabilization that is required for the pelvis at that level, this might require bone, vascularized bone grafting, possibly even free tissue transfer as a fibula with soft tissue reconstruction, depending on or even for I guess visceral loading from the standpoint of obliterating dead space. So these are all options that would be on the table. If you're looking at S3 and below being removed, I think that would be enough for the patient not to require bony stabilization. And I think that's probably the biggest portion of this. But I would also not rule out nerve grafting, because there's a high likelihood that you're going to be sacrificing several of the sacral nerves. So immediate nerve grafting can help, certainly for a pain perspective, not always function, but sometimes, and sometimes for sensation issues as well. So all these are on the table.
Thank you so much. Yeah, I think that brings us to our time for you to claim credit. Thank you all so much for joining us. Thank you to all of our panelists. We hope you enjoyed and learned something, and we'll see you again at the next Live from Cleveland Clinic.